So the first case, this is, as you can really see here, there are numerous cytogenetic abnormalities, and majority of them are deletions. So next slide. And when we look at this particular case, we see that there is that our computer algorithm diagnosed this particular case as diffuse large B-cell lymphoma. But what's striking about this particular case that, and as highlighted in red, in the red circle here, there is overexpressions of TNF-RSF17, which stand for the BCMA messenger RNA. We do see overexpression or increased in plasma cells in diffuse large B-cell lymphoma. But as you can really see in this particular case, it is completely different. It is almost 5.6-fold higher BCMA messenger RNA as compared with average B-cell lymphoma. So this is very high BCMA messenger RNA. As you can really see, the level here is 642 units of RNA, and this is very high. But at the same time, if you look at this case, the CD19 is high, CD22 is high, BDL1 is not high, it is at only 1. But if you look at KI67, which is in the middle, MKI67 is the same as the KI67. It is very high at 700. As a matter of fact, we also analyzed the BCMA, and it is at 900. So this is very high. MYC is very high, but MYC is significantly higher than the KI67. So it is not perfect, but definitely has MYC overexpression and has BCMA overexpressions. And this is not your typical diffuse large B-cell lymphoma by all means. Next slide. If we look at the mutations, so we see all these mutations that typically we see in diffuse large B-cell lymphoma. So this is not unusual. Next slide. Now, when we classify this for GCB versus ABC, it is clearly it is ABC. By the way, we published about this classification and how it correlates with other types of methodology in a paper published in Blood recently. So definitely this is ABC, it is not GCB, but it is the aggressive form. But the most important part to me is this case more of plasmacytic differentiation or plasmacytic diffuse large B-cell lymphoma because of the because of the high level of BCMA messenger RNA, and definitely it is more aggressive because of the MYC. But BCL2 is not increased, so it is not double hit, and KI67 increased, but not to the level we usually see in Burkitt. So this is what this case, and I really like to see or to hear Dr. Leslie's comments on this particular case. So Leslie.
Yes, so this was a very complicated case. 59-year-old woman who presented to another hospital, had some hip pain, otherwise healthy. Unfortunately, it was kind of early 2020, right before COVID hit. Then her pain was progressing, eventually was using a walker. This wasn't really investigated, wasn't seeing the doctor much because of restrictions coming into healthcare setting, and then ended up coming in with a markedly elevated calcium, altered mental status, was found to have diffuse bony lesions, liver involvement, bilateral adrenal lesions, gastric involvement. Started with a bone marrow actually, and that was negative, and then ended up having a non-diagnostic biopsy, and then ended up having a biopsy at the outside hospital showing, they said, a likely non-GC diffuse large B-cell lymphoma, but really couldn't classify the type. They said the CD30 stain on the, the CD10 stain was indeterminate. Decided to treat the patient with dose-adjusted EPOC. And then after that, a few weeks later, the patient's FISH studies came back, which take quite a long time to do, sometimes suggestive of a double hit lymphoma, and that's when the patient was referred to me. The lymphoma had really progressed to the point where it destroyed her entire hip. So, she just completed high-dose chemotherapy. We escalated to McGrath regimen, so dose-adjusted EPOC is something commonly used in the community setting for Burkitt and high-grade B-cell lymphoma. We typically prefer the R-Codox M IVAC regimen or McGrath. So she was young and healthy other than the lymphoma, so we were able to escalate her to that. She just finished her treatment, did excellent. And really the NGS is important because there was some delay in diagnosis, in the double hit in the FISH. That takes a while, and this certainly comes back more quickly. Also, it's helpful to clarify the ABC subtype. We didn't really know the subtype based on our initial pathology, but I think from what's presented, that's very clear. And if this patient were to relapse, which I would expect to happen within the next year to two if it's going to happen, typically they have a really aggressive relapse, and kind of based on this profile and the ABC subtype, I would consider maybe immunomodulatory agent, lenalidomide or other, added to the salvage regimen based on some of these findings. So I think it was a really helpful NGS panel, and I think, in general, these high-grade lymphomas are sometimes challenging to characterize, so having this panel helps us get all our tests back more quickly.
Thank you very much. By the way, ABC are rarely double hit. By definition, double hit should be GCB. So I really think this particular case is more like plasmacytic types of, sometimes it is not unusual that you have translocation, but without significant increase in P2. This particular case, no question, it has a lot of MYC. So that's absolutely true. But the BCL2, I really don't think it is that high, so that's where this case is really very unusual, right?
I think too, with the several chromosome changes that you highlighted, if we were worried about Burkitt, typically it's a little more pure. We don't usually do cytogenetics on the lymph node biopsy. So I think that's really helpful for us too, to clarify, is this more Burkitt-like? Is this more diffuse large B-cell lymphoma? So that was another point that kind of stuck out in this case for me.
Thank you.